Beta blockers, as a class of drugs, are primarily used to treat cardiovascular diseases and other conditions. The beta-adrenergic receptor antagonists, beta blockers, are widely used to treat tachycardia, hypertension, myocardial infarction, congestive heart failure, angina pectoris, cardiac arrhythmias, coronary artery disease, aortic dissection, glaucoma, and other conditions. Beta blockers are also used for migraine prophylaxis, to treat anxiety, to prevent essential tremor, and to block the side effect of hyperthyroidism. They are also used to treat less common conditions such as long QT syndrome and hypertrophic obstructive cardiomyopathy. Non-specific beta blockers are also recommended for treatment of portal hypertension in patients with cirrhosis. The beta blockers act by competing with beta-adrenergic agonists such as epinephrine and norepinephrine for beta receptor sites. Classification. Two types of classification are generally used in beta-adrenergic blocking drugs. They are classification based on selection and generation-wise classification. Classification based on selection. Beta-adrenergic blocking drugs are classified into non-selective, that is beta 1 plus beta 2, and cardioselective, that is beta 1 drugs. Non-selective beta blockers are divided into without intrinsic sympathomimetic activity, with intrinsic sympathomimetic activity, and with alpha blocking property. Without ISAs are propranolol, sotalol, timolol. With ISA, pindolol. With alpha blocking properties are labetalol and carvedilol. Cardioselective beta 1 blockers, they are metoprolol, etinolol, acebutolol, bisoprolol, esmolol, betaxolol, celiprolol, and nebivolol. Generation-wise classification. Beta-adrenergic blocking drugs are classified into first generation, second generation, and third generation drugs. First generation, that is older and non-selective, they are propranolol, timolol, sotalol, and pindolol. Second generation, that is beta 1 or cardioselective drugs, they are metoprolol, etinolol, acebutolol, bisoprolol, and esmolol. Third generation, that is with alpha blocking and or vasodilator property. They are labetalol, carvedilol, celiprolol, nebivolol, and betaxolol. Mechanism of action. Beta receptors exist in three distinct forms: beta 1, beta 2, and beta 3. Beta 1 receptors located primarily in the heart mediate cardiac activity. It's mainly increase heart rate, increase blood pressure, increase inotropy and chronotropy, increase lucitropy, and increase oxygen consumption. Beta 2 receptors, with their diverse location in many organ systems, control various aspects of metabolic activity and induce smooth muscle relaxation. In the lungs, it increases bronchodilation, increase alveolar fluid clearance, and decrease systemic and pulmonary inflammatory cytokines. Beta 3 receptors induce the breakdown of fat cells and are less clinically relevant at present. Blockade of these receptors by beta blocking medicines is used to treat a broad range of illness. In beta 1, it decreases heart rate, decreases blood pressure, and increases stroke volume, decrease cardiac output, increase left ventricular filling times, increase preload, increase conduction velocity at SA and AV nodes, decrease TNF alpha, and decrease interleukin 6. In beta 2, it increase bronchoconstriction, increase TNF alpha, and increase interleukin 6. Beta blockers as a class of medications are essential drugs and are first-line treatment in many acute and chronic conditions. The catecholamines, epinephrine and norepinephrine, bind to beta-1 receptors and increase cardiac automaticity as well as conduction velocity. Beta-1 receptors also induce renin release, and this leads to an increase in blood pressure. In contrast, binding to beta-2 receptors causes relaxation of smooth muscles along with increased metabolic effects such as glycogenolysis. Once beta blocker bind to the beta-1 and beta-2 receptors, they inhibit these effects. Therefore, chronotropic and inotropic effects on the heart undergo inhibition, and the heart rate slows down as a result. Beta-2 blockers also decrease blood pressure via several mechanisms, including decreased renin and reduced cardiac output. The negative chronotropic and inotropic effects lead to decreased oxygen demand. That is how angina improves after beta blocker uses. These medications also prolong the atrial refractory periods and have a potent antiarrhythmic effect. Beta blockers are often categorized as selective or non-selective based upon whether they block both beta-1 receptors that are predominantly present in cardiac muscle and beta-2 receptors found in bronchial and smooth muscles. Beta-1 selective blockers are preferred for therapy of heart disease, whereas the non-selective beta blockers are preferred as therapy to prevent recurrent variceal hemorrhage in patients with cirrhosis and portal hypertension. Non-selective agents bind to both beta-1 and beta-2 receptors and induce antagonizing effect via both receptors. Examples include propranolol, carvedilol, sotalol, and labetalol. Beta-1 receptor selective blockers like etinolol, bisoprolol, metoprolol, and esmolol only bind to the beta-1 receptors. Therefore, they are cardioselective. Administration. Beta blockers are available for administration in three primary forms: oral, intravenous, and ophthalmic. And the route of administration often depends on the acuity of illness, disease type, and chronicity of the disease. Doses are available in various ranges depending on the specific medication. Outpatient prescriptions may include once-a-day dosing for longer-acting beta blockers such as metoprolol succinate. However, most beta blockers are often dosed at least twice per day. Certain beta blockers such as propranolol with a half-life of approximately 4 hours are dosed up to 3 or 4 times a day depending on the indication and dose. Adverse effects. Common side effects are those that are caused by beta-adrenergic blockade and include bradycardia, fatigue, dizziness, depression, memory loss, insomnia, impotence, cold limbs, and less commonly severe hypertension, heart failure, and acute bronchospasm. Contraindications. Beta blockers have been contraindicated in asthmatic patients. Non-selective beta blockers should not be used in patients with asthma. Patients who have either acute or chronic bradycardia and or hypotension have relative contraindication to beta blocker uses. Specific beta blockers are contraindicated depending on the patient's past medical history. Patients diagnosed with long QT syndrome should not use the drug sotalol. Patients with Raynaud phenomenon should avoid beta blockers due to the risk of exacerbation. Monitoring. The patient's heart rate and blood pressure require monitoring while using beta blockers. When using sotalol, the clinician must monitor the QT interval as sotalol has QT prolonging effect. Other side effects such as fatigue and weight gain can also occur with outpatients' beta blocker use. Toxicity. The antidote for beta blocker overdose is glucagon. It is especially useful in beta blockers induced cardiotoxicity. The second line of treatment is cardiac pacing if glucagon fails, and this may induce transcutaneous pacing or transvenous pacing. Potential acute toxicity can be mitigated by using extended release formulations as preventive strategy, which will delay peak toxicity.